Welcome to part 3. Here we'll discuss the workup of primary immune deficiency. And this is interesting because you can get a high index of suspicion when you only get the history. So here I insist on history. Because here the high index of suspicion when you ask about the age of onset of symptoms, whether during the first 6 months of life or after the age of 6 months or at any age. You ask about family history, whether there is parental consanguinity, similar condition within the family, sibling death of infection. And then you ask about the number of hospital admissions, which indicates the severity of infection, and previous medications, if there is antibiotics, if there are any other drugs that cause neutropenia, for example, or any medications that are specific for immune deficiency as well. The physical examination should include the general examination of all body systems and the local examination as well of all systems, the pulmonary, the neurological, the abdominal, all parts of the body. And then you shift to the laboratory test. Here I'm going to mention the basic tests that are available everywhere. And you have to do these tests and rapidly refer to an immunology center as early as possible. In the meantime, you have to exclude causes of secondary immune deficiency, which I'm going to mention in part 4. So here, what are the lab tests required to identify different PID diseases? We have 2 steps. Step 1, you do the complete blood count with differential. This is quite easy. And the step 2, measurement of immunoglobulin level. The laboratory evaluation of suspected PID cases, we have general rules. First, use age-matched reference values to avoid misinterpretation of the results. And all the tests should be repeated at least 2 times 1 week apart before you consider the diagnosis of primary immune deficiency. For step 1, we have to do the complete blood count with differential. And always use the absolute count, not the percentages, because you get the white cell count in number. Then you get, for example, the neutrophil percent of the white cell count. Here, I ask you to calculate the absolute neutrophil count, the absolute lymphocyte count. You have to look at the platelet count, including the mean platelet volume. And sometimes you find iron deficiency anemia due to the presence of chronic infection and malnutrition. In cases of lymphopenia, the HIV infection must be excluded first because it gives similar blood picture and similar pattern of the immunoglobulins. The step 2, measurement of serum level of immunoglobulins, the IgG, IgA, IgM, and IgE. You have to refer to the age-matched reference values in infancy and childhood, but here there is a rough rule of thumb, which when the IgG is less than 1000 milligram per deciliter, this is abnormal. When the IgM is less than 100, this is abnormal. When the IgA is less than 10, this is abnormal. And when the IgE is more than 1000 international unit per liter, this is diagnostic of hyper-IgE. And whenever you find hypogammaglobulinemia, you have to exclude the secondary causes, like medications, especially the anticonvulsant drugs, nephrotic syndrome, in which we have the proteins are excreted in the urine, or the protein losing enteropathy. Here the proteins are lost in the stools, and the case of non-Hodgkin lymphoma. So how to interpret the laboratory results by step 1 and step 2? You can reach up to 12 diseases with these 2 basic tests. Here, if the absolute lymphocyte count is less than 800 per cubic millimeter with low IgG, then you have to suspect the immunoglobulins, all the immunoglobulins, then you have to suspect severe combined immune deficiency of the skin. If the absolute neutrophil count is decreased less than 500 per cubic milliliter with normal immunoglobulins, then this is a highly suspected the severe congenital neutropenia. If you have normal absolute neutrophil count and normal immunoglobulins level, then you suspect the chronic granulomatous disease. If you have increased absolute neutrophil count more than 20,000 per cubic milliliter with normal immunoglobulin levels, then this is a case of leukocyte adhesion defect. Thrombocytopenia, low platelet count. If you find this finding with low platelet count, thrombocytopenia in a boy, then suspect Wiskott-Aldrich syndrome. Normal CBC with absent or low immunoglobulins, this is a predominantly antibody deficiency. Normal CBC with normal immunoglobulins, then this is a case of complement. So as you can see, it's very simple that you can diagnose many of these diseases. Of course, if we have normal complete blood count with high IgE, then this is a case of hyper IgE syndrome. At this stage, I would ask you to early refer the patient to a specialized center. Don't consume time with techniques with expensive laboratory tests. The specialized center will be able to confirm the diagnosis by advanced laboratory tests, doing molecular studies and rapid intervention and management. And here we come to the management of primary immune deficiency. There are general guides that, like the diet, you take the diet of failure to thrive, you have to give ample calories. General management, you keep the patient in a germ-free environment, isolation. The antibiotics can be used in acute illness and as a prophylaxis. And you have to be very careful while using the blood and blood products to avoid the whole blood transfusion, because in combined immune deficiency, the whole blood may cause graft versus host disease. Avoid all live vaccines, as we mentioned before, the BCG, the oral polio vaccine, rotavirus, measles, mumps, rubella, yellow fever, oral typhoid, or live vaccines are contraindicated in immune deficiency patients. The curative therapy, which usually takes few months to be done, the replacement of what is missing. The immunoglobulin G replacement therapy, whether by intravenous immunoglobulin or sometimes it is used as subcutaneous. If the cells like the T cells are deficient or are abnormal, then we do the immune reconstitution or by hematopoietic stem cell transplantation. This is a curative therapy for the X-linked agammaglobulinemia, for severe combined immune deficiency, the SCID, for leukocyte adhesion defects, for the chronic granulomatous disease. Sometimes fetal thymus transplantation is done for DiGeorge syndrome and the genes therapy, which is still under trial. The prognosis of primary immune deficiency, it results or depends on the three pillars. Timely recognition, early diagnosis offer better prognosis, and that's why we ask for early referral of suspected cases to a specialized center. The adequate therapy and follow-up of the case and the nature of the underlying immune deficiency disease, because some of these diseases we have no proper or suitable lines of therapy, curative therapy I mean. This is here you can see that primary immune deficiency, where are we now? Actually, we are still working on the tip of the iceberg. The diagnosed cases represent the tip of the iceberg, but current estimate indicates that many as 70 to 90% of primary immune deficiency diseases are still undiagnosed. These patients experience lifelong complications and disabilities that result from untreated primary immune deficiency. And now I expect you to read this part 3 and wait for part 4.